Thank you and welcome to the Eureka Springs Hospital Commission meeting of April 21st, 2025. Can we have roll call, please?
David Carlisle, Commissioner.
Sharon Doremus, Commissioner.
Kate Dreyer, Secretary.
Vivian Smith, Commissioner.
Brian? Sandy Martin, Chair.
Lana Mills, Nursing. Bobbitt Schultz, Nursing.
All right, we have quorum. We need to approve two sets of minutes. First one is for the approval of the special meeting minutes on March 15th. Do I have a motion to approve?
Motion to approve.
Do I have a second?
Second.
All in favor?
Aye.
Any opposed? Hearing none, motion carries. Next is the approval of the March 17th regular meeting minutes. Do I have a motion to approve?
Motion to approve.
Second?
Second.
All in favor?
Aye.
Aye.
Any opposed? Hearing none, motion carries. Approval of the agenda for today's meeting. Are there any additions, deletions, corrections? Do I have a motion to approve?
Motion to approve.
Do I have a second?
Second.
All in favor?
Aye.
Aye.
Any opposed? Hearing none. Agenda is approved as presented. Public comments? Do we have any public comments?
My name is Heather Wilson. I've met some of you and others know me through FOIA requests and the papers. Nutshell, early career long-term acute care, followed by 3 cancer diagnoses and 10 years of creating and leading global continuing medical education symposia for doctors, pharma, associations, hospitals, etc. I've carried inspiring and awful experiences with me through that work as a compass as I move forward. I've stayed close to healthcare ever since, serving on nonprofit executive committees of the American Cancer Society and as a spokesperson for the Leukemia Lymphoma Society's team in training. Today, I own a small business specializing in recruitment, marketing, and employer branding, and a lot of my client work is focused on attracting and retaining top healthcare talent, board-certified physicians, dentists, behavioral health specialists, et cetera, for rural clinics and healthcare systems across the USA. My master's is in human resource development, and I'm working toward a doctorate in organizational development and leadership with a focus on, rural healthcare systems. I began teaching college students in the fall. While my dissertation won't center on the hospital as I'd hoped, it has become the focus of much of my academic work. As such, I've reviewed thousands of pages of documents, quite literally, meeting transcripts, CMS and Arkansas Code, traced the hospital's history back nearly a century, spoken with attorneys, professors, the Arkansas Department of Health, dozens of former hospital employees, and experts in the field. I also hold a city social and behavioral research certification, which provides training in ethical, responsible research involving human participants. So suffice it to say, from the access I am afforded, I do my best to conduct due diligence. As such, I've thought a lot about your recent workshop with the City Council, and a quote stood out: "Principles over personalities. The Commission's actions do not reflect this. They suggest otherwise. Your bylaws make you responsible for setting criteria for medical staff and outline what criteria to which you must adhere. CMS and Arkansas codes advise background checks. I've reviewed 2 of your management contracts, which have conflicted with your bylaws. I'm awaiting the current one. Where were the due diligence requirements? Your bylaws also say the CEO, not the CFO, creates budgets. Have they changed? They're not on any website for the public to easily access. This isn't semantics. These are 2 very different roles. The list of contradictions continues, but I've only got 3 minutes. Principals are not attempting to block legal FOIA requests to the Municipal League. Principals aren't blaming the press for doing their job. They're not pointing to one save to excuse a history of repeated failures. Principles aren't about creating the false impression that taxpayer money isn't involved in hospital funding. It is via state and other taxes. Principles are about accountability, not deflection. I've read hundreds of the pages that you call the other side. They don't show employer branding, culture building, or a commitment to healthy work environment. They do show a pattern of years-long failure and toxicity. You keep saying, look at the other side. I have quite literally the backs of your staff as they have been turned to the community, as today they are again. So have you looked at the other side, really looked? Principles over personalities. I challenge you to live up to that statement, like making
Time's up.
yourselves more accessible. I want to point out the logo. My last sentence. Please take a hard, long look at your hospital logo. Please. Some of you are nurses and doctors. I know you know what that means. Please don't let that be indicative
Heather.
of what the hospital will become. Thank you.
Thanks for sharing.
Thank you. Any other public comments? Okay. Jody and Cynthia are not here because they are with our accountant, Forbes. And somewhere, I've got Jody's report. Hang on. No. I don't know what I did with it. Strange. Well, a couple of things that I remember from it. It's weird. Sorry about that. We had, I'll kind of go into this a little later, but we had an alignment meeting with the UAMS people on telehealth that went very well. We are getting a report from our consultant, the Rural Health Redesign Center. They're doing a comprehensive report for us on financial status, assessment, opportunities for growth in revenue and outpatient services. So they're coming in sometime at the end of May to make that presentation to us, so that'll be good. Everything else is going well at the hospital. And I will continue to look for the complete report because there were a couple other things in there. Anyway, more on that. Everything was positive. There was nothing serious on anything. So we're good on that. CFO report, you all have a copy of it. It's a little over $6 million in the bank. The third sheet in is revenue by cost center. We had been down on emergency room visits. However, it's picking up. In April, we've had 83 already. It's ticking up quite nicely on that. The next page, the income statement, a couple things I want to point out with that. We had the anticipated hit this month, as you remember, from the backlog of Oracle invoices. We had held those during the transition and the training because it wasn't done appropriately. That's been resolved, so we did catch up, and we are now current with Oracle, and they are now paying a little bit more attention. We also bought under the purchase services, which is where the Oracle invoices are. What's included in that is IT, ER physicians, staff agencies, independent contractors, and our dietitian. And you remember we took about a $280,000 expense to buy all new equipment for Pinnacle to redo our network, make it more secure. The admin team is reviewing all areas for cost savings. There's a need for an increase in necessary stock of supplies in ER. Clinical team is doing a review of supplies and discounts. And basically, that covers most of that. Any questions on the financials?
Sandy, you said the IT equipment upgrade for security was around $320K?
No, it was around 285 out
$285?
of the 320. Yeah.
Okay.
So we had other services in there.
Thank you.
So the net loss this month was half what it was last month?
Yes,
Even with all those expenses?
yes.
That's good.
It is good. And we're still, I mean, month to date, we had net revenue of 463,303 versus last year of 521,184. So, we're low, and we know that, but we're going to address that. We're going to address that when we look at the budget as well with the finances. Any questions?
But the IT stuff, I mean, that was a one-time deal, right? And so we don't, our security's been upgraded, and as far as we can foresee, Pinnacle is saying we're in good shape for that, and there, other than monthly monitoring, there wouldn't be a big outlay of expense of dollars for any more equipment. Is that how you understand it?
That is correct. We had to get the equipment, 2 reasons. One, so they could start working on it and get us phased in without losing any operation, plus to avoid the tariffs. We wanted to do that as well. So the rest of that, it's a multi-year agreement with them that they'll be doing it. But we've got all the equipment they need to start working on it. So
Thank you.
that was a must that we had to do on that. Any questions on the financials? Okay, great. Okay, we have Lana and Velvet with us for updates. Lana?
Good morning or afternoon. A couple of things that I wanted to bring to attention or point out is that whenever we had the workshop, or the commission had the workshop with the city council and the latest city council, there were some comments made about the lab and the treatments of a couple of our patients. And one comment that was made was that a member said that they felt the commission had gaslit them. And it was about the NSTEMIs and STEMI treatment at the hospital. And with you, I gave you a couple of sheets, and I would like to educate a little bit on the NSTEMI versus the STEMIs. And you will find sheets from the Arkansas STEMI Advisory Council and from the American Heart Association. And if you look at sheet number 1, one side is the thrombolytic pathway from the Arkansas STEMI, and the other one is just the primary pathway. On both sides of that sheet, I've highlighted the STEMI diagnostic criteria up at the top. The next box is, again, STEMI diagnosis, and in both of those boxes, you will not find lab work.
Right.
At the bottom place where I've highlighted on both of them, it even states may transmit lab work after door out. And so you can, again, on the other side, may transmit results after door out. They want these patients out of the facility within 30 minutes. On the second sheet, it has 2 columns. One is for the NSTEMIs, and one is for the STEMIs. Underneath the NSTEMI, and the difference between NSTEMI versus STEMI is NSTEMI has non-ST elevation on the EKG, whereas STEMI has ST elevation. That is the diagnostic criteria for the differences. NSTEMI is a partial blockage, where STEMI is a complete blockage. STEMIs need to go directly to a definitive care. They need to go straight to that cath lab to make the difference. It's a life-saving measure. In STEMIs, there's a different treatment. They do a diagnostic from the troponin test. They also can have a different treatment. So if you look at here under the NSTEMIs, they need the troponin test. The STEMIs do not need to have that diagnostic criteria from that lab work. So,
Thank you for that clarification. It was a little disturbing to hear the comment from the council at the time that the comment was made, acting like we were idiots. Well, or the hospital was not functioning. Or it was something about conflating that a lab was necessary for the patient to get good care, but it was not that kind of care that was needed. The lab could come along later.
yes, and a lot of times the STEMIs are diagnosed out in the field. Whenever the ambulance, if a patient calls 911, that STEMI can be found out in the field. They transmit that. They call a STEMI alert for us to know. And if you look on that sheet, it even states if it's come in by ambulance to leave that patient on the stretcher, because that time is valuable. You want them out of your facility into the receiving facility for care.
Thank you, Lana.
So Lana, correct me if I'm wrong, I think 2 sessions ago is when you brought sort of your before and after numbers for your out-the-door numbers,
Yes.
where prior to your arrival for many months, our out-the-door numbers were far longer than what they should have been. But since you arrived and instituted some new clinical policies and procedures, maybe not formal P&Ps, but just following the P&Ps that we currently have, that your numbers for out the door have decreased dramatically. And I believe that the local papers were given those times also, that your handouts that you brought and gave to the rest of us, that our local journalists have copies of that.
Yes, I gave them to them that day.
Okay, that's what I thought. All right, just clarifying that what you gave before is connected to the teaching that you're giving us today.
Yes.
Okay, thank you.
Any other questions for Lana? Thank you very much. Sylvia?
Update for trauma.
Yes, you're on.
Designation survey for the Arkansas Department of Health will be June 4th that they'll be here. It was originally to be in February, but as you noted in your March 17th meeting that had to be, an extension had to be given because there had been no information available to the state as far as had we accepted the original date, were we going to decline it, were we going to ask for an extension.
And
So it'll be
that
in
was
June.
supposed to be done in May
Correct.
with completion by October, right?
Correct.
It was never done by
It
previous?
was never done.
Thank
Yeah,
you.
but, so we will undergo survey June 7th, or June 4th.
Okay.
The state will be here. Since that time, what will happen during that session is that the state will come in, they'll ask for, there's a list of things that they'll review: education, patients' charts, meeting minutes, pretty much the whole trauma program. They're going to ask to have it laid out so they can take a look at it. There'll be deficiencies assigned for things that are delinquent or they don't agree with, things that they have issue with. Clearly, you'll get deficiencies from any there's no activity that I can find from May 2024 on of any charts reviewed, no meetings, no education, no anything at all. I can find no record of anything. So they'll go back and be able to look at 2022 to 24 as a history, but that will not appease them. So we have went in since the 1st of February, and here's just to give you a little laundry list so you don't think I don't do anything, Sandy. We've created 6 clinical practice management guidelines, updated those through the state website for traumatic brain, anticoagulated patients, geriatric, open fractures, transferring out the trauma patient, and the revised TXA usage. We now provide a follow-up letter to all EMS when they deliver us a patient. A lot of times EMS has no idea what the outcome was, and they don't have a way to know that. So we're now sending back a letter to the EMS that brings us a patient to say, patient had brain bleed, patient had fractured hip, whatever it was, just to give them an idea of that follow-up.
Good.
We also created a new process improvement sheet that mimics our registry. Our registry is basically our database that every hospital dumps into the state registry, which dumps into the national registry. And so that's for your information, like 68% of drivers are unbelted. That kind of information comes from a trauma registry, and our little registry dumps the state that dumps national. So our PI sheet now reflects that. We had new trauma logs and new ER logs we've developed. Our goal with length of stay, currently we were at 6 hours as of the 1st of February. The gold standard and the state ask is to get an acute trauma patient out of the ER in less than 2 hours. And we're closer. We're about 3.5 right now, but we're far cry from 6 to where we were.
Yeah, that's great.
The 2025 trauma grant has been requested and is under review, and they asked for no further documentation, which is always a good sign. And we're just waiting on them to stamp it and return it. They approved the budget change, and that'll be a $50,000 ask. They really want you to do it throughout the fiscal year, but apparently no money had been requested up until the first part of March, of when we set to reconcile with them. So that's been sent in, so we're waiting on their approval. We'll apply for the next year at July 1st. We actually do it in June, and then they'll grant it in July 1st, and we can use it shortly thereafter. We will look to use it all fiscal year instead of all at one time. We'd rather submit it.
So the grant from last year, you have to spend by when?
We've already spent it.
Okay.
It's basically a receipt grant.
Okay.
So we had bought equipment and we had used salary. So we changed. We really didn't do a lot of education. We didn't do any travel for the education. So the change that we ask in the budget change form is to convert that over to equipment and salary.
Great.
It's that you can either move it around or you can lose it. And we asked to move it. We spent it on other things. That's just not what the original budget that it was drawn out for.
Was that used to purchase the carts?
It was.
Yeah.
We purchased the chest trauma supplies, the suture cart, the splinting cart, an airway cart, and 2 sets of emergency airway supplies.
Great.
Intubation supplies to upgrade them. We went the disposable route as opposed to trying to clean individually the old supplies. With that also, we had to upgrade all of our education records. No education records had been updated since 2022. We now have availability to a community outreach program called Think First. It's actually really generated for elementary and junior high school kids. It was developed by a neurosurgeon, and the Northwest Arkansas Trauma Track, of what we're a member of, actually has bought us a membership. We've probably had it 3 years, and I can't find any record where we've ever used it. But basically, they provide whatever program we ask for in a box, and then we can take that and deliver it to the school systems. Helmet use, water safety, bicycle, skateboard, seat belt, drugs and alcohol, whatever. You just go through and pick the program you want, and you get with your school system and see what they'd like. It comes with all the literature, the written materials, the audiovisual materials. It's all provided all through the Think First program. And they stamp our logo on the bottom. So when we provide it to the children, it has Euclid Springs Hospital on the bottom.
That's cool.
The trauma track paid for us as membership, so we can use it and we won't be billed for it. So we might as well use it. It's a great program. We also contacted Arkansas Children's, and we'd like to host an advanced burn life support course in this area. One's not been provided in this part of northern Arkansas probably in 4 or 5 years. There was one in Rogers and Bentonville about 5 years ago. Arkansas Children has agreed to that. They get a grant to bring that class to us at no charge for 25 members. We'll be offering it obviously to the community, but they'll put priority to EMS and healthcare providers in this area that would like to be certified in advanced burn life support, because we don't see a lot of them, but we get enough of them. We need a little updated education for them. I guess from trauma standpoint, that's where we'll be. We'll know where we're at in June, and we'll have a report out at the end of that day, so you'll know where they stand. I fully anticipate deficiencies. I can't fix the past. All we can do is show them the future and what we've redeveloped and revised. But they are well aware of the situation and are very excited and willing for us to get back online to be able to do trauma at a little higher level.
Thank you. What have you been doing?
I know. I'm reviewing charts. I'm at about 125 so far. We've had to review.
Thanks for digging into those
Yeah,
grants and getting
absolutely.
everything squared away. And I know you've been in constant contact with the state as well, so
Question.
appreciate that.
Sure.
So after you gave us the before and after picture of the trauma survey,
Yes, ma'am.
you listed several things that gave us, or that gives us a before and after picture. So if you wouldn't mind, so that I can fold it into the minutes, perhaps I could get a copy of your notes.
Sure,
If
absolutely.
that's all right with
Yeah,
you. And
absolutely.
instead of you having to go back I just want to give a very clear before and after picture to let the community and the rest of the state know how much ground we have gained and how hard y'all have been working. And we really appreciate it a lot.
Well, and what's kind of interesting to make note of is my background is much larger facilities, level 1 trauma burn centers, and this is the exact program that they use, just in a condensed version. The practice management guidelines, the policies, the process improvement, all the way down to the meeting minute template is all the exact same. It's just a trauma program in a box.
Thanks so much.
Sure.
Any other questions or comments? Appreciate that, a tremendous amount. Thank you. That's a lot of good activity and a lot of good community outreach as well. I did remember one thing that is important that was in Jody's report. For 4 years now, we have given a scholarship to Eureka Springs High School, $1,500. We did it again and have the recipient, and the ceremony is going to be at the high school on the 14th of May. I can't tell you who won because he or she does not know they won either and won't until that day. But anyway, we're proud to be able to do that scholarship every year for the high school students that want to make healthcare their profession. Okay, anything else at all from the table? Okay, Dr. House, thank you for joining us today.
Thank you, Doctor.
Thank you.
Thank you.
Thank you.
So as you all know, our little hospital was established in 1929 as the Don Sawyer Memorial Hospital. By the 1940s, it was the Carroll County Hospital, and in 1952, it was named the Eureka Springs Hospital. It's clear when you read the history of our hospital that it has faced numerous challenges over the years, including closure many times. So this is the situation that we've been in over the last couple of years is not necessarily a new one. But through all of that, the doctors, the nurses, the staff who work there remain committed to providing the best health care possible for our community. So the Commission's bylaws, which were updated in 2022, give you the authority to manage the hospital, to hire and fire staff, even to levy taxes, to borrow money, to contract with the company to operate the hospital, as well as many other privileges. As I'm sure you're painfully aware, however, running a hospital can be a full-time job. So to that end, my goal today is to show you how I can be your partner in achieving your mission of operating a top-notch healthcare facility for our community. So let's get started. If you will look at your the first white page, which is page number 2, I want to recap the proposal just briefly that I sent to each of you in your email. I don't want to go through everything because I don't want to drag this out too long. But the high points are that my proposal is that you partner with my company, HHLS, to manage the hospital in totality, including all patient care, financial management, compliance with government regulations, public relations, staffing decisions, etc. The Commission, and this is important, the Commission would retain all legal rights to operation of the hospital. The REH license would remain in the name of the Commission. The Commission would retain its credentialed status with all current payers and would be added to any future payers. All funds generated by the Rural Emergency Hospital clinical activity at the hospital, as well as any incentive money from government programs such as Medicare, would continue to be deposited into the Commission's bank account. Now, the reason I bring that up is because when I joined this Commission back in, 2015, I think it was. And Allegiance was running the hospital. They kept all the money, and then they just paid us rent, basically. They rented the license from the commission, and they rented the building. So the only accountability they had to the commission was strictly what was in their contract. And it did not give us much accountability. So I wanted to make it clear that the commission would still be 100% in charge, just as you are now. In exchange for that, then you would pay my company $650,000 a month to cover everything else. Now, there was some balking at that number, I think, initially, but if you look at your expense reports over the last 12 months, it's a little bit more than the average of that monthly expense. So obviously, the only way that I can stay in business is if the expenses are covered, particularly if you're getting all the money. So that money has to flow back to my company to pay payroll and to pay all these contracts for equipment and those sorts of things. Now, as the situation improves and the revenue to the hospital increases, then the amount that you would pay my company would go up as well. The reason behind that is that presumably that increased revenue would come because we've hired additional staff, we've brought in new equipment, we're offering new services. So that would be to cover those expenses. And we'll talk a little bit more about that in the really brief financial stuff I have here. Now, my company would bring in its own management team. We would provide the staffing to meet the hospital's mission, just as you would expect. So on that part, and by the way, if you have any questions while I'm going, feel free to just interrupt me. Yes, ma'am.
The ER physician group, can you comment on that now? On whether or not the current ones would stay or you would bring in a whole new ER group?
So I can't really comment on that. I don't.
Okay.
I haven't seen that contract. I don't know anything about that.
Okay.
Beyond what I've read and what I've been told. I don't. From what I have seen from the ER notes that we get, they seem to be pretty competent, and at this point, I'm comfortable with them. And the ER doctors have to come from somewhere. So, you know, I can't say for sure, but no, wouldn't necessarily have a problem with them.
And just to follow up on that, would it be a group, or is your idea to maybe have a physician A, B, C, D, and create your own ER group, I guess?
So that is something that, by the way, the team that I have in place, the executive team, if you will, the director of medical services is an ER physician, and he and I have not discussed specifically whether those would be employees or contract labor.
Okay, so, thank you.
Yeah. Yes, ma'am.
Doctor, I have a question on the $650,000.
Yes.
Does that cover all salaries?
Yes.
All salaries, all expenses, except
Yes.
what you...
Everything related to running the hospital.
And you have a management team already, or...
Yes.
Okay.
Yeah.
Okay, thank you.
Yes. So if you'll look at your green page, I've got some financial projections on there. Now,
Excuse me, Dr. House, back
Yes,
to the
sure.
expenses. Don't you have in here that the commission is still responsible for other maintenance and expenses?
yeah, well, for exterior maintenance of the building, yes. So
Wasn't
thank you
there
for that
a-
clarification. So as you know, the original building was built in 1929. The, quote, new building was built in the 1970s. And frankly, it has had minimal maintenance. That was part of the reason that we terminated Allegiance's contract with the hospital, was because they were not maintaining the building. And I know you've heard some on city council mention that they're concerned about the status of the building. So anything that would have to happen outside, you know, like let's say that the roof caved in, that would be the commission would have to come in and repair that, which is a fairly typical thing you see in commercial leases. The property owner maintains the exterior of the building, makes sure that it is usable. Beyond that, the person who's leasing the building takes care of everything. So everything inside, any remodeling that we would do, anything that would break down, we would take care of. Now, you do know I have an exception in there that if, let's say the boiler, that I don't know anything about the boiler, but let's say it's
fixed.
Okay, good. But let's say there's a similar piece of equipment that's 50 years old, and it had a life expectancy of 25, and it's $100,000. Well, that would be unrealistic to expect us to absorb that cost when it should have been replaced 25 years ago. So I just put an exception in for that. I don't think that that would be a very common thing to happen. But obviously, any medical equipment, CT scanners, lab equipment, anything that we would use diagnostically would be our responsibility.
Okay.
So,
Thank you for the clarification.
sure.
Okay.
Excuse me, Doctor?
Yes.
Oh, sorry.
Yeah, no, go ahead.
Oh, I didn't mean to interrupt. So I have one more question
Yeah.
because I still have questions about management team.
Sure.
And so how many people are on your team and what positions?
So we have 3 people who have committed on the management team.
Okay.
Myself. I can't mention the other 2 names because they are currently employed with someone else.
Okay.
But one's an ER doctor and one is an RN who has 25 to 30 years of hospital management experience.
Okay. Thank you.
You're welcome. So what I was going to say there is that this proposal is just a proposal, okay? So if there are things that you're like, gosh, we like what you say, but this is a deal breaker, we'll talk about it. We can figure that out. And then once we get it all worked out and ironed out, then our various attorneys will sit down and make it all pretty and legal. So now on your green page, I was going to say that about the projections. Projections are worth about the paper that they're printed on,
Right.
okay? So this is just kind of fanciful thinking of where we're going. And I kept it really, really simple because I wanted to point out something. If you go back pre-COVID, revenue in the hospital was $1 million a month. Wasn't always that, but it was frequently that. And when Allegiance was operating, of course, we had inpatient and swing bed then, so that was an additional revenue, but it was also additional cost. But at that time, the revenue was $1 million a month or more. So in the first year, if you decide to use me as a management company, in the first year, I project that we will get back to $1 million a month pretty quickly. So that's the number that I've included there. Now, I've got an assumption there that this implies that the economic climate and the political climate stays the same. That's a big assumption. But at this point, don't have any other way to rectify that. As Sandy mentioned a while ago, the tariffs and trying to buy stuff before the prices get high. Who knows what's going to happen with that? But given that all things stay the same, I feel confident within a year we'll be back to where we were a few years ago. And the reason that I included then those expenses of what you would pay my company is so that you can see that on that fourth quarter, the commission is bringing in $136,500 more than you're paying out. Now, to put that in perspective, at the bottom, when Allegiance was making $1 million a month, they were paying us $6,000 a month. I think by the time their contract ended, it was higher than that. It was either $7,000 or $15,000. I can't remember. I'd have to go back and look at the minutes. Mm-hmm. But it was still a very small amount that the commission was getting, and so all of that money was flowing into Louisiana. Okay, so let's look at the next page here. I want to talk about community outreach. So I'm wearing 2 hats today. One is as somebody who's proposing to manage the hospital, but the other is as a local physician. And and I'm sure that anybody that's worked in clinical care can vouch for this, but doctors, nurse practitioners, we are incredibly busy. And when we do something, when for instance, on Saturday, I saw more than 30 patients. And so when I ordered a CT or I ordered physical therapy or speech therapy, I want it to be once and done, right? I want to know, I place that order, it's gone, the patient will get called and scheduled. That has not happened with our hospital. It's still not happening with our hospital. So we need to fix that. And that's part of the management proposal, but it's also a perception. So when we think about how do we improve this, first off, we have to talk to the doctors and nurse practitioners. We have to convince them that that problem is fixed. Because I'm a founding member of the Carroll County Medical Society, and I can tell you that if you ask those doctors, do you feel like Eureka Springs Hospital is a reliable place to send orders? They will say no. Okay? So we got to fix that. One of the ways that we can fix that is me. These doctors trust me. So if you decide to go with me, every week, I and a member of the staff, whether it be radiology, lab, nursing, whomever, will be going, and we'll be going to these doctors' offices and these various places that order from Eureka Hospital and saying, hey, you trust me. Let me make this right for you. Yes, ma'am.
So, since your management of the hospital couldn't happen, overnight, when I hear you say that they can't get their orders completed in a timely fashion, the offline, the more specific that you can be with us, the more quickly we can make changes that need to happen today.
Okay.
Okay, that would be most helpful.
So
Thank you
you'd rather
much.
hear about that offline? Is that what you said?
I think that would be more constructive to
Yeah,
be able
I
to just
agree.
have a.
I agree.
Thank you.
And I'd be happy to share that with you. So, the second group that we have to work with to convince them that the hospital is in good standing is the public. So the number of orders that I have sent to the hospital over the last 6 months to a year has probably gone down by about 90%, maybe 95%. And in almost every case, the patient says to me, oh, I don't want to go to Eureka Hospital. Now, they don't want to go to Fayetteville. They don't want to go to Rogers. So we're sending people to Mercy and Berryville. And I'm here to tell you that's not going smoothly either. But they haven't read in the newspaper and seen on YouTube and talked to their neighbors about all of the stuff going on. So they don't want to do that. They don't want to come back here. And when I talk to them about it and I say, well, if you're willing to do it, I'll send that order. They'll say, no, we don't want to do that. Now, I may be a little full of myself here, but I believe that if I told a patient, look, you trust this clinic, will you trust what we're doing at the hospital? They would say yes. And I believe that we can turn that around. So we would focus on, again, going to Rotary Club and Lions Club and Chamber and churches and schools and being on the print media and social media and, and saying, here, look, here's what we're doing that's good. And here's why you can trust us, because your neighbor is the person that's going to take care of you when you get there. That doctor that you know and you've known for years is there and is going to take care of you. So I think that's a really important thing that we have to focus on. And then the third thing is rebuilding trust in the extended medical community. So it came up a while ago, somebody mentioned about the cardiologist in Fayetteville that made a comment about would not go to our ER for an NSTEMI or for a heart issue. So that's because, again, even in Fayetteville and other places, the nurses there are talking. The rad techs are talking. These travel nurses are talking. And the doctors are hearing about that. So we have to work to convince them that, hey, we know what we're doing and we're doing a good job. And part of the way you do that is by creating an environment where every member of the team, from the person cleaning the floors to the person starting a central line, knows that they have a voice. And that if they have a problem, they can talk to the top person and say, here is what my issue is. And not worry about being fired. Okay, so that's the way I operate. Every person in my clinic knows that they can talk to me about whatever it is, and I'm going to take it seriously. And if it's an issue that we need to deal with, we will deal with it. So you put those three things together, and I think we can repair this damage that's been done over the last year. All right. Moving on. Gets talking and feel like I'm back in a pulpit or something. All right, if you'll look at your yellow sheet, I just want to touch on this briefly. I know that there was mention of Mercy in Berryville, mention of bringing in other outside management companies or even talking with the CEO. And obviously, again, this is back to wearing my hat of the person trying to make this partnership with you, so it's a little biased. But in the rows there, I listed, for instance, time to establish relationship with local physicians. Day one, that relationship is there if you work with me. A remote management company, maybe 3-6 months, maybe more, maybe less. A CEO, I think one of your candidates, somebody mentioned that at the workshop, said it would take 2 years for them to get back to where we were in that respect. Understanding of the community's medical needs. Again, day one, I live this medical community every day. Our clinic is open 7 days a week, so we deal with this every day. We know what we need. We know what's missing. And so I wouldn't have to do a focus group or a study to figure that out. We just have to figure out how to pay for it. A remote management company might not ever get that figured out. A CEO, again, just speculating, maybe 3 to 6 months. Commitment to strengthening healthcare in Eureka Springs. And this is important because in our remote history, Washington Regional ran the hospital. And part of, now this is purely what I've been told. I don't have any documentation about this. But what I was told, the reason that the commission canceled the contract with Washington Regional was because they were not willing to put anything into the hospital. And everything that, just the smallest thing, they would just transfer them over to Washington Regional ER. And so they had no real skin in the game as far as what was going on in Eureka. They didn't care necessarily if Eureka's health care was as good as what they had in Fayetteville. I think it was kind of their idea, well, why should we duplicate the wheel? We'll just send everybody over there. There was another one that I thought was kind of important. So the very last one, where does the money go? I want y'all to understand something, because somebody in one of these meetings made a comment like, well, what's in it for him, in referring to me? And I can tell you what's in it for me. It's better health care for our community. 100% of the profits that we make off of this will go back into investing into this hospital. I'm at the end of my career. I'm not looking to build some great, medical empire or something. I want to do what's best for our community and make sure that when I do finally retire, that there's a hospital around the corner, not 60, 70 miles away, that I can go to when I'm having an NSTEMI or a STEMI or a stroke or whatever else may happen. And I think that most people in this town feel that way. They want this hospital to stay. And so I will take every penny above and beyond what it costs to run it and put it right back into this hospital. A remote management company, as we've seen in the past, will not do that. It will get siphoned off out of our community, and it will go, who knows, line somebody's pockets. The very last thing I wanted to tell you is just kind of a little fun experiment for me. When I moved here, I think 12 years ago, and went to work for Washington Regional, before I actually set foot and saw my first patient, I went over to the hospital because I was just enthralled with it. It was just such a cool little place. And I walked around and I thought, wow, this is so cool that I'm going to be working in this little country hospital. And immediately I started hearing about, they're going to be building another hospital and, maybe tearing this one down. And I was kind of heartbroken by that. But there's not going to be a new hospital built in my lifetime. It's just not going to happen. And so we have to focus on what can we do to make the building we have the absolute best it can be. And the middle initial on the REH is emergency. Yet if you look at the floor plan on our building, like maybe 10% of the building is the emergency room. So I've drawn out some plans. I do have the entire hospital on a floor plan, but I only zoomed in on the ER portion. Otherwise, you wouldn't be able to see it. And just to kind of give you an idea here, in that upper right-hand corner of the drawing, the ambulance bay reoriented, and you see these top 2 rooms up here. Probably be easier if I had a projector, but these top 2 rooms here are the 2 trauma bays. Having worked in that ER, I can tell you that our trauma bay is inadequate when it comes to space and room to get everybody in there. And so these trauma bays are twice the size. And then there are 2 more ER rooms that are kind of in the, what we call the, used to be the inpatient portion. There's 2 rooms there. The nurses' station quadrupled in size so that everything can be there where the nurses need it, and they're not having to get stuck in some little cubby hole somewhere. And then you'll notice on down that there are 4 urgent care rooms. So one of the things we do in my clinic is run urgent care. And if you and I form a partnership, then that urgent care will be in our hospital. It will no longer be in my clinic. So we'll need rooms for that, and those urgent care rooms would operate on the weekends and before most clinics open, and the ER doctors would staff that. Then the specialist also could use those rooms and have true clinic rooms with nursing staff and everything right there in the same space. But those are just flights of fancy right there, and maybe that'll happen, maybe it won't. But just give you an idea of my commitment to the success of this facility and this hospital. I really, really want to start sending people back to the hospital. But the only way we're going to do it is if we fix some of these issues. So, any questions?
I'm glad to hear that that you have confidence in the current ER group.
Yes.
And I certainly have confidence in that group and with our chief nurse. So I think you could send somebody over today if you needed to.
Some of my patients have gone to the ER, some because they just felt like they wouldn't be able to get anywhere else, or maybe they had transportation issues, and they got good care. So,
thanks for that feedback.
Yeah.
Thank you for this. It's well thought out. You put a lot more time into it than I thought. So it's good. It's good. And you remember we tried to build under Allegiance or Alliance, one of the two, a new hospital.
Yes.
And it's got to be 35 miles away from,
Yes.
which put us out in Inspiration Point, which was impossible to build anything. So it's remodeling for sure.
Yes.
And, the commission had a goal of doing that, but it was a pricey endeavor that we just decided was not in the books.
Right.
But I appreciate this a lot. You know that we are proceeding with the CEO candidate.
Yes.
And you know the process we have to go through in considering this, not only the RFP, but also the state notification to 2 different departments. And just as a clarification, we can't lease you the license. It has to stay in.
Right.
So just as a point.
So no, I would not want that arrangement. I would work for you.
Yeah, okay. And, okay, so that's all I have. I thank you. There's a lot
Thank
here.
you for that comprehensive and far-reaching plan.
Yes.
Thank you.
It is. And, as we go down the road, because again, just to be fully transparent with you and the community, we are focused on moving forward with the hospital and doing everything we can. So we want a CEO as quickly as possible.
Right.
And to that point, we want a CEO that does, on some of these uncertains, are certain.
Right.
Yes, they're healthcare specialists. Yes, they know healthcare financial. That was part of the weeding process, I think, that the search committee did. We'll also, and I'll talk about that in a little bit, We are very aware of the community issue and the reputation damage that has to be done. We also have plans of working on that, because you're absolutely right. And we, too, take all of those allegations seriously. And we are continuing with an investigation with an independent firm. And, we'll have a report once we identify that independent firm. We want somebody with, totally separate from the commission and our attorney, so that it's unbiased and fair. So we have plans to work on that hopefully, should we do a partnership, you won't have to work so hard, at it, because the community relationships needs to be repaired now.
Yes.
And the hospital needs to move forward now, and I think we are. We're getting a lot of the things, as Velvet said, a lot of the things that were biting us last year because of lack of getting anything done is now being corrected. We're making slow, steady starts. So, but we look forward to continuing the conversation with you, and appreciate you coming, and appreciate you giving such a comprehensive report.
Question.
Anything I can do, I'll be happy
And
to
your
help.
passion, your patience
Yes.
and passion.
Yeah.
So let's go back to the ER remodel.
Uh-huh.
The way your plan is set up, is it something that could physically be done in stages based on, since the commission would be paying for it, and it wouldn't come out of the $650 per month?
No, the remodel would come out of what? It would come out of cash that you would pay to me.
Okay. Well,
But-
either way,
Yeah.
do you see that it's something that could happen in stages?
It would have to.
Great.
Yeah,
Okay.
I mean, unless you're planning to put mobile homes out in the parking lot or something,
Right.
it would have to be done in stages.
Okay.
Maybe a third at a time, that kind of thing. So
Thank you.
you're welcome. Anybody, feel free to email me. I think all of you have my email, and
I think
be
we
happy
all
to.
do, because
Yeah.
you sent it to everybody, and I made sure everybody has your initial proposal. So
Yeah.
if you can electronically send me this,
Sure.
digitally email this, because this would be good for all of us to have
All right, very good. We'll do.
as well.
Thank you.
Thank you, Dr. House.
Thank you, Dr. House.
Okay. Just a quick mention, update with UAMS IDHI. Jody, Cynthia, and Lana and I met with Chris and Brenda from UAMS IDHI, and it's a good, strong beginning, I think. And Lana, you can chime in if you want to, but they are very anxious to get us started. They went through the facility, they measured, identified where the telehealth room would be, a community room as well. We talked about also putting the second machine in the Huntsville clinic so that we could get there and then eventually go up to Holiday Island, which would be good, or vice versa, depending. They are very anxious to work with us on the open house. And it looks now with schedules, it's really getting difficult to schedule everything, but it looks like early June. So if you all could look at your calendars, you don't have to do it now, but look at your calendars and see if there's a date in early June that works for you. I'll give it to Chris and Brenda and make sure that that they can make it. They want to bring up their clinic partners and everything else as well. We'll introduce the community to the staff that they haven't met yet, 360. We'll have Pinnacle there to answer any questions as well. Intention is to invite our U.S. and our state representatives and senators. As you all know, Congressman Womack is extremely supportive of the hospital and knows its importance, particularly as a tourist town. So I'm sure he'll show up. And Harlan Burrow will, and Brian King will as well. So that's hopefully what we're going to do, and then launch the telehealth. UAMS will bring a telehealth cart up, so there'll be demonstrations, and hopefully some educational material that we can start distributing at that time. Do you have anything you want to add from that meeting?
No, there's a lot of different educational opportunities, like you mentioned, for a community room for people who may not have access to internet or a computer at home, that they would be able to come in and use a community room to get that information. So if they have maybe newly diagnosed diseases or something that they need to learn about, that they could come there and get that information. Also, with the telehealth, they can get specialists, that they could get information there. We could log on to different doctors with the UAMS.
They talked a lot about helping us develop more outpatient services as well. And Lana, which I thought was a good point, brought up psych. It's like void here, and prenatal. And they're working with, I think, 2 different organizations on both of those fronts to develop a partnership that hopefully could come by. So that was a real good meeting. It was real exciting and looking forward to more. We will have them at a public meeting when we get closer and they get their plan and everything done. So, but any questions you have, let me know or let the staff know, and we can go from there. Okay. CEO search committee update. Kate?
Yeah, and thanks again, Dr. House. Yes, we have 2 finalists. So I brought their information again in hard copy so that we could move. I'm making a motion to go into executive session so that we can discuss these 2 candidates. And
I have a motion from Kate to pause the regular meeting and go into executive session. Do I have a second?
Second.
David, second. All in favor?
Aye.
Any opposed? Okay, we will now go into executive session at 3:03. We're back to the Eureka Springs Hospital Commission meeting of April 21st. Do I have a motion to conclude executive session and resume our regular meeting?
So moved?
Second?
Thank you. All in favor?
Aye.
Okay, 100%. Thank you. Do I have a motion to extend an offer of unconditional employment to the candidate of choice?
So moved.
Do I have a second?
Second.
All in favor?
Aye.
Any opposed? Thank you very much. That's exciting that we're pursuing a candidate. Couple of just miscellaneous things. The date, we need to start kind of looking at our budget and reimagining it as we anticipated on that, starting with the financial thing. And a financial workshop with City Council we agreed to. So I'm thinking that the date for that workshop could be Thursday, May 22nd. And the reason for that date is we asked the Arkansas Hospital Association to come up and give a state of the state of hospitals in Arkansas, and particularly rural, which could be educational for everybody. And that's the date that they said they could come up from Little Rock. So if that works for everybody, I'd like to set that date.
Okay, as far as I know, I'm
Good, good.
I believe I'll be in town.
Yeah.
I think so.
Brian, you good May 22nd? Okay. Everybody's good. So lock that date in. We'll do it like, in the morning. It'll have to be a public meeting, so I'll have to check on what time, because it'll have to be here at the Odd. And I'll invite City Council as soon as I get those logistics squared away. Thank you all. Okay, Commissioner comments. And Brian, you can scoot off if you want to. Thank you, Brian. Bye-bye. Commissioner comments. Vivian, start with you.
I don't think I have anything to add. Thank you.
Kate?
I appreciated Dr. House, the effort and the thoughtfulness. And appreciate Lana and Velvet's effort. I do have a question, though. Are our workshops going forward going to be down here?
Yes.
Okay, so I'll make that change when I do the minutes then. How's that?
Yeah, and again, I've got to double check on the schedule with the Odd, make sure that we're okay with that. Because with moving it to 2, there's a 4 o'clock cemetery commission today right after us, so I got to make sure that the workshops are clear. But yes, they will start being here.
Thank you.
You're welcome. Sharon, anything?
Not really, just ditto to what Kate said.
I think we're moving ahead very nicely, getting back into a regular rhythm with a competent administration in the House. And I thank Dr. House for his excellent presentation.
Yeah, it was good and thorough and more
It's
than I
very
expected.
promising.
Yeah, absolutely. Appreciate that and appreciate all the public comments. One thing that Velvet and I talked about earlier, or last week, that she forgot to mention, she gave us at the workshop the information on the standalone ERs. And she said, what do you think about a field trip? Taking the commissioners all on a field trip to a standalone ER and kind of seeing how that looks. And I said, it's terrific. Where's the closest one? I was hoping it would be like Montreal, but it's not. It's Fayetteville. But if y'all think that's a good idea, I'll have her coordinate it and get back to us with some dates so we can do that. Be an interesting field trip.
Maybe it would even be a date that our medical director, our chief doc,
Yeah.
Roberts, could go with us. Just not.
Yeah.
He's doing a wonderful job, but information's a great thing to have. Yeah.
Absolutely. And they're working on some ideas for us, and which sound kind of exciting. I don't know what they are, but the way they're phrasing it, and Misty, the COO, sounds like they're excited about it, so I'm excited about it. They're going to be on our agenda at our next commission meeting. And Dr. Roberts, as well as Misty, the COO, and maybe one or two other people will be at the meeting too to do a presentation. So that ought to be good. With that, I just want to thank the commissioners for their dedication. I'm really excited, and I agree with you, David. I think we're moving positively. We're moving forward. I appreciate our focus that stays on the hospital and moving forward. And I'm excited that we have a candidate to start talking about that's critical to the future. And it's critical to everything that we do in the community and for the community. Next workshop is May 5th, 2 o'clock. Hopefully it will be here at the auditorium. And then the next regular meeting is May 19th, 2 o'clock. With that, I'll take a motion to adjourn.
So moved.
You almost didn't want to adjourn, huh? Second?
Second.
Oh, yeah, there's, Vivian's anxious. All in favor? Aye. We're out of here. Thank you all very much.